right, and then it just looks like Tyler's on. That's it.
Yep.
Good morning.
Good morning. All right, I'll mute myself and you can get going whenever you want.
Okay, awesome. Just shut up.
Perfect.
All right. So my talk is on exercise physiology, which is definitely not the most invigorating talk of all time, but it's definitely something that's PAQ relevant. So I figured it's something to a bit refresher to get that biochem back in our minds. We got to give a shout out to Dr. Schrader, because she's actually the one who wrote this chapter in the textbook for the spin-off book.
And it's a super duper important topic for CAQ because it's not something we talk about a whole bunch in the clinic setting, but there's so much testable material.
So we'll start off at the basics, so looking at muscle structure. So each muscle cell is made up of all sorts of different aspects of it. So muscle cells themselves are long, cylindrical, and multinucleated cells. The muscle cell membrane is called the sarcolemma. The cytoplasm is called the sarcoplasm. And when you have a bundled group of muscles cells, it's called a fascicle. And then each fascicle is contained into other bigger sections. So you have endomysium, which surrounds each muscle cell, and then sarcolemma is continuous with the endomysium. Then you have paramysium, which surrounds each fascicle, and then you have epimysium, which surrounds multiple paramysiums and is around the entire muscle. Obviously we know that tendons connect that muscle to bone, periosteum, and actually the endomysium, paramysium, and epimysium all connect to the tendon. That's something good to know. As far as innervation, each muscle cell is innervated by a single motor neuron, but a single nerve can innervate multiple muscle cells. And a motor unit is considered a single motor nerve in all of the muscles that it innervates. And we have this thing called the all or nothing phenomenon, which is that all of the muscle cells in a motor unit contract when they're stimulated by their motor nerve. So if anything connected to a single motor nerve, it's either all on or not firing at all. So looking at the breakdown of the smallest aspects of it, we have the myofibrils, and that's the contractile apparatus of the muscle. It's composed of myofilaments, myosin, and actin. Myosin is the thick filament, actin is the thin filament. And myosin has this globular head, which forms a cross bridge with actin and binds and has a conformational change. And that's what actually shortens the muscle. Actin has a two-stranded double helix structure that's initially covered until it is bound with ATP. Sarcomere is the smallest contractile unit in skeletal muscles. And I know they love talking about all these different lines of the sarcomere. So the Z line is the end lines of the sarcomere. That's where actin is attaching to the Z line. The M line is, I think of as the middle line, and that's the center of the sarcomere, and that's where myosin attaches. So then you have these bands. So the A band, it contains both myosin and actin, and the I band contains only actin. And then you have this phenomenon of the H zone, which is in the middle of the A band, and that's the section of the A band that only has myosin. And the H zone and I band get smaller, but something that they love testing as well is the A band that never changes in size. So at rest, there's minimal calcium in the sarcoplasm. There's only a few myosin heads that are bound to actin. And you have this troponin and tropomyosin that are covering those actin binding sites on the myosin head. During contraction, acetylcholine is released from the motor neuron end plate, binds the receptors on the muscle cell membrane, causing depolarization of the sarcolemma, which then is transmitted rapidly into the interior of the muscle cells via these T tubules, and intracellular calcium is released from the sarcoplasmic reticulum, and that calcium binds to troponin, which causes a conformational change in tropomyosin and uncovers those myosin binding sites on the actin filament. Myosin head then forms a cross bridge with the actin filament, flexes and disassociates. myosin head then recocks to its original position, and then the whole phase starts over again. And it takes 2 ATP that to each time you do this, because you need 1 ATP to form that cross bridge and flex, and you need 1 ATP in order to disassociate the myosin from the actin, so it can recock. As far as muscle fiber types, we think of 2 true muscle fiber types, type 1 and type 2. You know, they now have some subtypes of type 2 that we'll talk about here in a second. But type 1 is our slow twitch and oxidative. These are going to be our endurance type of muscles. They're not going to have they're going to have a slow contraction speed and low force production, but they have very high endurance due to these aerobic enzymes and high concentration. They also have a high amount of mitochondria and a myoglobin. And you know, these are the red muscle cells, like people like to call them. Type 2 overall is going to be your fast twitch muscles. And they focus mostly on glycolytic or anaerobic forms of metabolism. They do have talked about the type 2A is this kind of combined oxidative glycolytic. Which is going to have some increased kind of intermediate type of endurance. And 2X is going to be a true, just like normal glycolytic, high speed, easy fatigability type of muscle. As far as muscle fiber recruitment, so there's this principle called the Henneman size principle, which means that, you know, whenever you want to fire a muscle, those smaller, lower threshold motor neurons that innervate these type 1 fibers are going to be recruited first. And if you need more force, then those larger type 2 fibers are going to be recruited if needed. The only exception to this is high velocity activities such as plyometrics. Those type 2 fibers are actually going to be recruited first. So like we talked about, there's kind of 3 energy systems that the muscles use primarily for force production and ATP production. So the ATP phosphocreatine, the anaerobic or glycolytic, and the true aerobic. And we're going to break down all of these here in a second. So the ATP phosphocreatine is the main energy source for maximal effort exercise lasting up to 30 seconds. And what happens there is phosphocreatine donates its phosphate to generate ATP from ADP in the muscle. It's catalyzed by the enzyme creatine kinase, and most of the phosphocreatine in the body can be regenerated after resting around 3 minutes. So this is a whole principle as to why supplementing with creatine works. You can increase that creatine, which will eventually get stored as phosphocreatine in the muscles. You have a higher amount of phosphocreatine available, lets you do this maximum effort energy for 30 seconds or so. Then you have the true anaerobic or glycolytic phase, which is metabolism of glucose to pyruvate via glycolysis. You do not need oxygen for this. It produces 2 ATP if you start with glucose, or 3 ATP if you're starting with glycogen. And in the presence of oxygen, the end product of glycolysis, which is pyruvate, is metabolized via the aerobic energy system. And so when pyruvate is created faster than it can be metabolized, then it's reversely converted into lactate. And the conversion of pyruvate into lactate is facilitated by a low oxygen environment. And this is something that can be trained, and we'll talk about later. Glycolysis is the primary energy source for exercise, lasting between 1 to 3 minutes. And the rate limiting step of glycolysis is catalyzed by the enzyme phosphofructokinase. And so anything over 3 minutes, you're going to be relying on the aerobic metabolism. We talked about this aerobic or oxidative metabolism. So that's going to be occurring in the mitochondria via oxidative phosphorylation, which has 2 parts. So again, put on our biochem hats, think about the Krebs cycle. So in the presence of oxygen, pyruvate is converted into acetyl coenzyme A, and the substrate, which is the substrate for the Krebs cycle, through a series of reactions, cofactors such as NADH are produced. And the byproduct of the Krebs cycle is CO2. And then after that, you go through the electron transport chain. And so cofactors such as the NADH and FADH are oxidized to store energy, and ATP synthase is used to convert this stored energy into ATP. And the byproduct of this is water. So those are things to know. And each glucose molecule in the aerobic system produces 36 ATP. So if you think about, the net ATP from both glycolysis and oxidative phosphorylation is 38 if you start with glucose, or 39 starting with glycogen. Just put these in case you wanted to cry a little. With the electron transport chain, Krebs cycle. And there is also a different type of aerobic metabolization, which is fat. And triglycerides are broken down into glycerol 3 free fatty acids by lipolysis. And these free fatty acids enter the mitochondria and are converted back into acetyl coenzyme A through beta oxidation, which then again goes into the Krebs cycle and electron transport chain. The important thing to note here is that the free fatty acid metabolism is way higher ATP production than glucose alone. Each palmitic acid molecule, which is the free fatty acid that this uses, produces 129 ATP from one palmitic acid. So definitely a lot higher. As far as the lactate kinetics, this is something that people have talked about for a long time. It's still kind of a debated topic in exercise world, but at rest and during low intensity exercise, blood lactate levels are low and remain relatively constant. As intensity increases, there becomes a point above which the lactate begins to accumulate due to a low oxygen environment. And if that exercise intensity continues to increase, a shift takes place where anaerobic metabolism becomes the predominant energy source rather than aerobic. And that's just called the lactate threshold, and occurs at about 4 millimoles per liter of blood lactate. And this, like I said, it can be trained. So in untrained individuals, the lactate threshold may reside at around 50 to 60% of their maximum oxygen uptake. Whereas in trained individuals, it may be closer to 80 to 90% of their maximum oxygen uptake. And the big thing here is that lactate is an energy substrate for glycolysis. And as far as we can tell, it does not actually appear to cause the muscle burn that people associate with exercise. So then I've always been like, well, what the heck does? And the answer to that is, oh, we don't know yet. So still trying to figure out what causes that muscle burn, but everyone says it's not lactates. As far as adaptations to exercise, obviously depending on what you're training, you're going to be focusing more on those type 1 or type 2 fibers. So people who are doing a lot of aerobic activity, you're going to have increased muscular capillary density, again, because you need that oxygen. You're going to have more mitochondria, same reason. You're going to increase your oxidative enzymes. And you're going to have increased fat metabolism with prolonged aerobic exercise. And you can have conversion of those type 2X fibers to type 2A fibers. But again, this is something that they're like, well, maybe you can. So never can take anything for face value in medicine. Whereas with aerobic exercise, the big things you're going to see is increase of those anaerobic enzymes, and you're going to increase your lactate buffering capacity. All right, so again, digging into this a little bit more, when you are doing aerobic exercise, it's going to increase your muscular capillary density, the size and number of the mitochondria, the number of your oxidative enzymes. It's going to increase your fatty acid transport across the sarcolemma and increase fat metabolism. You're going to be more efficient in arterial oxygen extraction, and you're going to have an increased arteriovenous oxygen concentration difference. And because of the fact that you can have this increase in fat utilization, there's actually a relative sparing of glycogen or glucose metabolism, which results in a reduction in lactate production. There's going to be no change in muscle cell lactate buffering capacity, and pyruvates can be metabolized faster due to this increased oxidative enzymes. So as far as this conversion thing, so historically studies have suggested that many type 2X fibers will convert to type 2A fibers after 2 weeks of aerobic training. However, now these newer techniques defining muscle fiber type have emerged, suggesting that this probably doesn't actually happen, but it's controversial and they're still trying to figure it out. And then anaerobic exercise, you're going to have increased or anaerobic enzymes such as phosphofructokinase, phosphorylase, and lactate dehydrogenase. There's gonna be a moderate increase in your oxidative enzymes, and you're gonna have an improved muscle cell lactate buffering capacity. So if we do resistance exercise, what happens? Obviously, the whole point here is you're trying to cause a muscle cell hypertrophy, and this is going to be due to the increased number of sarcomeres. You don't actually increase the number of muscle cells, you increase the sarcomeres. Occurs after about 6 to 8 weeks of consistent training, and it's predominantly happens in those type 2 muscle cells. And the strength gains that occur prior to those 6 weeks are actually due to neural factors, and including improved motor neuron recruitment and repression of those self-protection reflexes. So people, a lot of times when they go from being untrained to start doing resistance training, will notice huge gains in strength in the first 6 weeks or so, but not any change in their size. And then sometimes they can actually get kind of frustrated because after that, they will start to get a slow increase in their muscle, but they don't have that fast gain of strength they were in the beginning. So people can get, a little discouraged sometimes. And like I said, there's no substantial evidence supporting hyperplasia in humans due to resistance exercise. We already talked about that kind of fiber type conversion, but we think it's controversial. Resistance exercise can actually lead to improved aerobic exercise capacity, which is evidenced by improved running economy of long distance runner following a maximal squat strength training 3 times weekly for 8 weeks. And aerobic exercise does not appear to enhance the strength benefits of resistance training alone. So doing resistance training can help with endurance, but endurance does not help with strength training. Resistance training also increases bone mineral density, increases ligament and tendon strength and collagen content, and increases your anaerobic energy stores. So through glycogen and phosphocreatine, and your capillary mitochondrial density actually will decrease due to a larger degree of muscular hypertrophy. And so you're going to need more capillarization of those. And since you're focusing on mostly anaerobic anyways, you don't need as many mitochondria and capillaries. When you have high volume and low load resistance, that's going to increase your creatine phosphokinase, myokinase, and phosphofructokinase. You have lower volume but high load resistance exercises, you're actually going to see a decrease in creatine phosphokinase, no change in myokinase or phosphofructokinase, and lactate dehydrogenase concentrations don't actually change with really either of these. Looking at flexibility, there's 3 main stretching techniques. Static stretching is the one that everyone kind of thinks of. That's where you just kind of stand there and you hold a muscle in a stretched position for a sustained period of time, usually around 30 seconds. And these are easy to perform. They take very minimal activation of the muscle spindles. And the big thing here is they're actually been found to be detrimental, which when they're performed prior to events requiring major strength or power. So that's why we've kind of started to get away from doing static stretching prior to events. It's very good after your exercise. Ballistic stretching is using a bouncing motion and is utilized to stretch the muscle. It's going to activate a lot more muscle spindles, causing a reflex contraction of the muscle and being stretched. And it's as effective as static stretching, but in theory, more painful, and there's a potential for injury here. This PNF, or proprioceptive neuromuscular facilitation, is when you have a contraction of either the agonist or antagonist muscle during a particular stretch. So if you're trying to stretch the hamstring and contract the quadriceps, that's how that happens. A lot of times it was talking about you really need a second person to help facilitate these. And however, this PNF has been found to be the far more effective technique compared to the other 2. Static and ballistic are about this equal, but PNF is superior to both. So what factors influence flexibility? So your joint range of motion is going to be limited by your bony anatomy, as well as the muscles, fascia, tendons, and ligaments that cross the joint. Your muscle elasticity is going to reduce with age, and that's because you're going to have a fibrocartilaginous replacement of degenerated muscle fibers, increased adhesions and calcium deposits. Females are generally more flexible than males, and that's primarily due to their pelvic structure and hormonal differences. Physically active people tend to be more flexible than their sedentary counterparts. And you can increase your flexibility due to your acute musculotendinous viscoelastic properties, or chronically if you are increasing your sarcomeres from this constant stretching, it'll actually increase your stretch and pain tolerance as well. So what is the cardiovascular response to exercise? So as exercise intensity increases, there's a linear increase in heart rate. Your stroke volume will increase initially, but then it will plateau. And early increases in cardiac output are associated with exercise are due to a combination of both increased heart rate and stroke volume, whereas the increased cardiac output associated with higher intensity exercise is nearly completely due to heart rate. So if we think about this, so as we get to these really high heart rates, you can't actually fill all the way, and so that's why your stroke volume is not going to continue to increase. So there is a linear relationship between cardiac output and oxygen consumption, and cardiac output is therefore an important determinant of aerobic exercise capacity. During a prolonged aerobic exercise session, there is a gradual increase in the heart rate and decrease in stroke volume at a given workload. And this is called cardiac drift, and is likely due to a greater percentage of the blood being diverted to the skin for heat dissipation and a reduction in blood volume due to sweating. And during aerobic exercise, your systolic blood pressure will increase proportional to exercise intensity, but it has very little effect on diastolic blood pressure. And they've seen that during resistance exercise, there can be extreme increases in both systolic and diastolic pressure, greater than 400 over 300. And that is especially in the setting of Valsalva maneuver, where they're really bearing down prior to the lift. Well, I don't know if terms. Again, cardiovascular response to exercise. You're going to have an increased stroke volume at rest and during maximal exercise, left ventricular wall thickness, internal diameter, and mass. Your blood volume is initially going to be increased due to the increased plasma volume, and likely due to increased antidiuretic hormone and aldosterone levels. Later on, your blood volume is going to increase due to both plasma volume and red cell number. So as you do a lot of aerobic exercise, you're actually going to have increased erythropoietin from the kidneys and have higher blood volume concentration. And since this increase in blood volume is greater than the increase in red blood cells, there actually is a net reduction in hematocrit, which is referred to as a pseudoanemia, which you can see in the numbers. You are going to have a decreased resting in submaximal exercise heart rate, and you're going to decrease your systolic and diastolic blood pressure. Long-term resistance training does cause increased left ventricular wall thickness and mass with no change in internal left ventricular diameter. So basically, you're going to make the heart be able to pump harder and stronger, but you're not going to be constricting any amount of blood flow or decreasing your stroke volume. The respiratory response to exercise, initially you're going to have a rapid increase in ventilation, followed by a brief plateau, and then another gradual rise until a steady state is reached. And during submaximal exercise, this increased ventilation has a linear relationship with oxygen uptake, and initial increase in ventilation is due to the increase in tidal volume. With increased exercise intensity, your breathing rate becomes the predominant mechanism for increased ventilation. So you do hit, like again, we said, it's steady state. What is some of the endocrine responses? So with testosterone, your testosterone is actually going to temporarily increase after resistance exercise. Testosterone is increased by shorter rest periods. So if you rest for only 1 minute rather than 3 minutes, the one downside to this is if you're not resting that 3 minutes, you're not going to be able to build back up your phosphocreatine stores. And if you do less intensity but higher volume, so if you're focusing on more than 10 repetitions rather than 5 repetitions, has been shown to increase testosterone. And any exercise lasting longer than 20 minutes is going to increase it. It is going to lower. So endurance athletes actually have a lower than normal resting testosterone level, which is just something interesting to me. Growth hormone is also going to increase after resistance exercise. It's same kind of thing as testosterone is going to be increased by those shorter rest periods, less intensity but higher volume, and any exercise less than 20 minutes. And your growth hormone actually does increase after aerobic exercise. That's the difference there. Insulin and cortisol. So insulin is going to decrease during exercise, and insulin sensitivity will increase after with exercise. And your cortisol is going to increase after resistance training and with prolonged aerobic exercise above 70% of that maximum oxygen uptake. Something else to know is, after exercise, you do have this big upswing in insulin afterwards, and for up to an hour afterwards, and that's kind of that idea of this like anabolic window where you want to have a lot of carbs and protein. So like trying to have a meal right after exercise can be beneficial because you can replete these muscle glycogen stores that way. As far as aldosterone and ADH, so you do have significant water and sodium losses with sweating, and your renal blood flow may fall to 25% of resting value during strenuous exercise. So you're going to have a decreased GFR. And with exercise, the renin-angiotensin system produces angiotensin 2, which stimulates thirst and stimulates the release of aldosterone from the adrenal glands and causes water absorption. You're going to have a decreased plasma volume and increased plasma osmolarity during exercise, because which will cause the hypothalamus to produce ADH, and this is going to restore total body water and electrolyte levels in the hours to days after exercise. Your highest risk of dehydration occurs during endurance events in the heat, as we all know, and consuming too many fluids that are not able to be excreted by the body can lead to hyponatremia. And post-exercise proteinuria is fairly common, and this is actually due to increased glomerular permeability and does seem to be related to exercise intensity. It's totally normal and not to be worried about. The neurological responses to exercise. So acutely with exercise, you're going to have alteration of serotonin, dopamine, and norepinephrine levels. And this response is going to be dependent on the type of receptors and neurotransmitters that you activate. You actually will also get that release of opioids and endocannabinoids, can promote a sense of euphoria, well-being, and anxiolytic effects, and that's what we think is likely what causes the runner's high. Chronically with exercise, you're going to see decreased stress through cortisol, which has a neuroprotective effect, and you'll actually have improved cognition exercise routine. The immune responses to exercise. So if you do low to moderate intensity exercise, you're going to have reduced infections in previously sedentary people, and that's going to have no effect on mucosal IgA concentrations. However, with these high intensity and prolonged exercise, you will actually decrease mucosal IgA concentrations, leukocyte counts, and natural killer cells for 3 to 72 hours after exercise. So you actually will have a decreased immunity in these prolonged endurance, high intensity runs. And so there actually, it can be an increase in upper respiratory infections in endurance athletes because of this. So delayed onset muscle soreness, or DOMS, and this is going to occur following high force, unaccustomed, eccentric, and occasionally isometric and in extended position muscle contractions. And again, we don't actually know why this is eccentric specifically, but the things that we know that occur after eccentric exercise, you're going to have disruption of the sarcomere Z lines, which we call Z line streaming. You're going to damage sarcolemma. Calcium is going to be released within the cell, and the calcium-dependent proteolytic enzymes will degrade the damaged sarcomere Z lines, which will then really cause neutrophil concentrations to increase in the few hours after injury. An important thing to know about this is that creatine kinase leaks from the muscle cells into the circulating plasma and will attract monocytes into the area within 6 to 12 hours of the injury. And these monocytes then transform into macrophages, then phagocytose the damaged structures, which then will release prostaglandin E2, and type 3 and 4 nerve endings are sensitized. Mast cells are attracted to the area and then release histamine, causing tissue edema, hyperthermia for further sensitization, and mechanical compression of nociceptors. Then this all peaks about 48 hours after injury, and oxygen free radicals are also produced throughout this process, causing secondary tissue damage. So they think that all of these kind of contribute together to create that sensation of DOMS. And the pain typically begins around 6 to 12 hours after exercise, peaks about 2 to 3 days after exercise, and resolves 5 to 7 days after exercise. These symptoms there's not really a whole lot you can do other than have them take some NSAIDs, Tylenol, massage, electrical stim, cryo, heat, and rest. The most effective prevention for DOMS is what's called the repeated bout effect. So if you do a single bout of eccentric exercise, it'll prevent the development of DOMS from the same exercise for about 6 weeks. We found that stretching really does not decrease DOMS at all. And there's limited evidence that tart cherry juice and BCAAs and caffeine prior to exercise can decrease the symptoms related to DOMS, but that's kind of lower numbers. And the tart cherry juice, you need like 357 milliliters of it 3 times a day for like 4 weeks before it starts to work. It was a weird study. In children, due to variable maturation rates, you classify children by their biological rather than chronological age. So their biological age can be determined by their skeletal age, skeletal maturation, or physical maturity. So basically the Tanner stages. Muscle mass will increase during maturation with about 25% of a baby's birth weight attributable to muscle versus about 40% of an adult's weight. This increase in muscle mass is due to hypertrophy, not hyperplasia. Pre-puberty strength and muscle mass is similar between males and females, but obviously, the males have a larger increase in muscle mass than females due to higher testosterone levels during puberty. And this larger increase is going to be mirrored by larger increases in strength. Females do have increased estrogen levels during puberty, which causes fat deposition, secondary sex characteristic development, and hip bone. What happens during pregnancy? So light to moderate physical activity during pregnancy has a minimal risk and has actually been shown to be beneficial. Exercise during pregnancy results in lower heart rate and increased heart rate variability, and which they think suggests overall improved cardiac autonomic control. During pregnancy, fasting glucose levels are decreased about 15 to 20%, and there can be a pretty rapid drop in blood glucose with exercise for them. And so there is a risk of hypoglycemia in the pregnant athletes, though something definitely to think about and make sure they're fueling appropriately. But we have found that exercise helps control blood glucose during pregnancy and decrease the risk of developing gestational diabetes. Hormonal changes result in increased joint laxity during pregnancy, and it's due to specific hormones that are produced during pregnancy to try to relax all the tissues around and get prepared for childbirth, essentially. But this may put a pregnant athlete at higher risk of joint pain or ligamentous injury due to that laxity. So again, with pregnancy, you're going to have an increased blood volume, increased heart rate, increased cardiac output, but decreased systemic vascular resistance. You're going to use more oxygen and you're going to have a higher minute ventilation. You could have a decreased functional residual capacity and decreased oxygen reserve. That, like I said, the maternal fasting glucose levels are decreased about 15 to 20%. Decreased plasma insulin in response to insulin. Obviously, increased body mass and increased lumbar lordosis due to that change in gravity and increased joint flexibility. So elderly, so as we age, we're going to have a decrease in muscle strength, mass, and this is due to loss of muscle fibers. And there's actually a preferential loss of type 2 muscle fibers and leads to a higher percentage of type 1 muscle fibers. And this decreased muscle mass will predispose people to osteoarthritis of the knee, falls, and osteoporotic fractures. Your endurance is going to be decreased due to that decrease in muscle mass, decreased capillary blood flow, oxygen uptake, and nutritional status. And we always have to think about chronic diseases being prevalent as well. So COPD, CAD, and CHF can all contribute to this as well. Their balance is going to be decreased due to usually inactivity and deconditioning and chronic diseases that affect balance, such as peripheral vascular disease, diabetes, Parkinson's, peripheral neuropathy. Again, usually they don't have the best nutrition. If they are history of alcoholism or some of their medications, this could all affect their balance. Their flexibility is decreased due to immobilization and or lack of regular joint movement through full range of motion, decreased muscle and tendon elasticity, and osteoarthritic bony hypertrophy. Balance training does reduce falls and osteoporotic fractures, and flexibility training does improve joint range of motion and muscle flexibility. So definitely something to recommend for elderly patients. So with the elderly, doing progressive resistance exercises can increase strength, endurance, submaximal aerobic capacity, and bone mineral density, and will cause a decrease in blood pressure, decrease your falls risk, decrease knee pain, and decrease disability. With aerobic exercise, it's going to increase their efficiency. So meaning, they're going to have a reduced metabolic demands for any given activity, going to increase their endurance and oxygen uptake, and can actually cause a lot of chronic diseases to feel better. You're going to have a reduced resting heart rate, disability, and pain. So this is just a chart talking about everything we just went over here a second ago. So patients with chronic disease, physical activity does reduce all-cause mortality and disease-specific mortality. These benefits do appear to occur in a dose-response manner and does not depend on the intensity of exercise. Regular exercise is a beneficial adjunctive treatment of chronic diseases, such as everything below. I'm not going to run through everything, but all of our chronic common diseases that we see can benefit from exercise prescription, basically. Focusing specifically on hypertension, about 50% greater risk of developing hypertension in sedentary people than active people. And people with hypertension, regular exercise can reduce the systolic blood pressure by about 7.4 and diastolic by about 5.8. Moderate intensity aerobic exercise is as effective as high intensity aerobic exercise at reducing blood pressure. That's something, again, to kind of counsel patients on. Some patients think that they have to do this really high intensity, but even tell them that moderate intensity aerobic exercise causes decreased blood pressure can be kind of reassuring for them. You do get some reductions in systolic and diastolic blood pressure from resistance training, and regular resistance training also blunts acute elevations in blood pressure that occur in untrained individuals who do perform these. You can get a small reduction, and these small reductions in blood pressure, so just dropping by 2 millimeters of mercury of both systolic and diastolic blood pressure, can actually decrease stroke risk by about 14%, decrease CAD risk by about 9%. And we believe that the decreased blood pressure is probably due to a reduction in sympathetic tone. In our patients with diabetes, aerobic and resistance exercise decreases insulin resistance and therefore increases insulin sensitivity. And this is likely due to an increased GLUT4 production, which is a glucose transporter protein, which will thus increase glucose transport in these diabetics. Aerobic exercises performed for 30 to 60 minutes, 3 to 4 times per week at 50 to 80% of VO2 max, reduces glycosylated the A1C levels by about 10 to 20% in type 2 diabetics. Circuit type resistance training or high intensity progressive resistance training performed twice weekly for 3 months decreases A1C by about 8 to 9% in type 2 diabetics. And high exercise intensity is more predictive of improved glycemic control than high exercise volume. So that's one of the few ones where the intensity is more important than volume. In regular physical activity, reduces mortality in athletes with both type 1 and type 2 diabetes. In our patients with hyperlipidemia, our triglycerides are reduced for about 18 to 24 hours after an acute bout of high intensity aerobic exercise. But a shorter duration and lower intensity does blunt this response. Your total cholesterol and LDL have small reductions following acute exercise, and HDL will frequently increase after an acute bout of aerobic exercise. And so if you're doing consistent aerobic exercise for 3 to 12 months, this can reduce your triglyceride levels by about 10 to 20%. Reductions in LDL are approximately 5% following over 12 weeks of aerobic exercise, but we found that total cholesterol does not appear to decrease with regular exercise. And regular exercise can increase the HDL between 4 and 25%. In our patients with depression, aerobic and resistance training decreases depressive symptoms in both men and women. And exercise appears to be as effective as psychotherapy for treating depression. The ACSM's recommendations for the treatment of depression with exercise is 20 to 60 minutes of aerobic exercise 3 to 5 days per week. For osteoporosis, physically active youth have higher peak bone mineral density than their sedentary counterparts. And the ACSM's position on exercise is that in the treatment of osteoporosis, recommends weight-bearing endurance activities such as moderate to high intensity 30 to 60 minutes of exercise 3 to 5 times per week. And stuff like jumping and resistance exercise at least 2 to 3 times per week. And the intake of calcium and vitamin D are important for bone health, but supplementation with excessive amounts has not been proven to increase bone mineral density. So you can't cure it just by taking some supplements. You do have to do this exercise as well. In obesity, weight loss requires more caloric expenditure than intake. So basically you have to be in a negative caloric balance. Dieting alone is going to be better for weight loss than exercise alone. However, once individuals have lost weight, they're more likely to keep it off if they participate in regular physical activity. And, this is something that a lot of people get stuck on. People are like, say, oh, I can't lose weight because I can't exercise. Exercise is only about 10 to 20% of the picture. Diet is about 80% of weight loss. You can't out exercise a bad diet. So that's definitely something to counsel patients on. Though there is something to be said about, regular, especially resistance training. People who do a lot of regular resistance training are going to have a higher muscle mass. And when you have that higher muscle mass, you're going to have basically increase your basal metabolic rate because of that, because muscles are very metabolically active. So this is the reason why you have the world's strongest men guys or these competitive bodybuilders. They have to eat an insane amount of calories just to maintain their weight. Regular aerobic exercise does modify multiple cardiovascular disease risk factors in obese individuals. So definitely something to recommend for them. That's me. Not the most exciting topic in the world, but definitely an important one and something that's CAQ relevant.
Yeah, it's super heavy on CAQs. I don't know, Mandy, if you're on, I know you just recertified. Any comments on specific areas to focus in studying?
Yeah, hold on, my voice is probably switching from Wi-Fi to cellular. So let me know if you can't hear me. So understanding the changes in heart rate and stroke volume and cardiac output and the cardiac drift and what causes cardiac drift, all of that is super important for the exercise physiology questions because that stuff doesn't really change. So it's easy to write questions on that. And so there's going to be some hopefully stuff on that because some of the other exercise physiology questions they ask are really complicated and weird. And I can only hope that those are kind of test questions. But and the hormonal changes I think are probably reasonable to understand as well for CAQ.
Awesome. Thank you for commenting.
But
I was
Justin,
gonna
you're way ahead. Now you don't have to study for exercise physiology bit very much.
Yeah. I'm gonna stop the recording for a second.